Ready?
Let's do it.
All right. So, good afternoon, everyone. Welcome to today's edition of our Multidisciplinary Endocrine Conference on Wednesday, March 15th. It is my pleasure to introduce Dr. Emily Montgomery. Dr. Montgomery is a product of the University of South Florida College of Medicine, where she received her master's degree in medical sciences in 2013. She then went on to receive her medical doctorate at St. George's University School of Medicine before joining the pediatric residency program here at the University of Louisville and Norton Children's Hospital. Subsequently, she joined us as a Pediatric Endocrinology Fellow, and she is currently our second-year fellow. Her preliminary work has been primarily in the area of diabetes. She has continued that work during her fellowship, and it is totally appropriate that she speak to us now about this topic today, which is DKA-HHS, mixed DKA-HHS, and the updated ISPAD guidelines, a case series and review. Please join me in welcoming Dr. Emily Montgomery.
Thank you very much, Dr. Wintergertz. Thank you for the introduction. Thank you. Like you mentioned, so we're going to talk a little bit about DKA-HHS and then hit a little bit harder on the mixed DKA-HHS because that's where a lot of the new stuff has been coming out. We'll talk about the ISPAD guidelines and go through a couple of cases. So I do not have any disclosures, and we'll talk about the objectives briefly. We're just going to kind of talk about the clinical presentation, pathophys, treatment, complications of DKA-HHS, talk a little bit more about the mixed DKA-HHS, especially what we've been seeing in the pediatric world, and then touch base about some of the updated ISPAD guidelines, looking at the new clinical practice consensus guidelines on DKA and HHS that they released this year. So it's the newest one since 2018. So here is a cool new graph. It just came out in Lancet, and I think it's a nice demonstration of what we have been seeing in clinic already. And I'm sure that you guys are also seeing the downstream of this because everybody that gets diabetes grows up and becomes an adult as well. And so you can see, I'm going to try to do this from here. The purple boxes are the overall population in both of these. So the top box is type 1 and the bottom box is type 2. And this is looking at the change in incidence from 2002 into 2018. And so we can see that there is definitely a rise in both of these, but the rise of the type 1, the incidence of type 1 is much less compared to the rise of type 2 that we see here. When we compare these, we had about a 2% increase per year in the incidence of type 1 and a 5% increase per year in the incidence of type 2. We see that there's a little bit of difference in the different ethnicities that were having such significant trends. We see that in the top, we have the non-Hispanic white group who really didn't have any significant changes in type 1, nor did they really have any significant changes in type 2, just kind of hanging out at the top of type 1 and the bottom of type 2. But you can see that there are other groups that had more significant changes. So your non-Hispanic Black population are the blue triangles, and they had a significant increase in both your type 1s and your type 2s, more so in type 2s, but definitely a noticeable change in both of them. We also see that the American Indian population had a pretty dramatic increase in type 2 that pretty well parallels or follows along with the non-Hispanic Black group. And then we see an increase in their population with type 1 as well as the Hispanic population and the Pacific and Asian and Pacific Islanders. They have a little bit more, sorry, I keep moving screen, increase in type 2, but we do see that there's a change in all of the different ethnic groups in type 1. So I think this is really interesting. I think it'll be even more interesting to see what comes of the data when we look after COVID started, because I'm sure as you all saw, quite a change in the rate of onset. We saw a lot more kids with diabetes, especially in the 2021, 2022, and the end of 2020. So I think that as we continue to see an increased incidence, we will obviously also continue to see an increase in hyperglycemic emergencies with DKA-HHS and the combined. And so for us, this is pretty important. I think it is interesting to note that a lot of, where was I going with this? these kids have been picked up in the outpatient setting. So our type 2s, about 50% of them are being picked up in the outpatient, like well child checks and stuff. So that screening is definitely really important. So here we have patient A. This is a 17-year-old female with known diagnosis of type 1. She presents with nausea, belly pain, she's thirsty, and she's having a hard time breathing. History, she was diagnosed with type 1 at 4 years of age. She's on MDI, and she's not particularly well controlled with an A1C greater than 15 before this admission. In the ED, she's a little tachycardic, her blood pressure is sustained, and her respiratory rate's around 22. She's awake, alert, oriented, she's pretty dry, she's Kussmauling, she's a little tender to palpation. As far as her labs go, her bicarb is low at 6, her glucose is 528, osms are 316, pH is 7.16, her CO2 is 26, bicarb is 9, her urine glucose is over 1,000, and ketones are over 150. So pretty classic DKA presentation. So the biochemical criteria: hyperglycemia, blood sugar greater than 200, venous pH is less than 7.3, serum bicarb of less than 18. This was a change from the 2018 guidelines that used a cutoff of 15. We've now increased it to capture a larger population. Ketones need to have either serum beta-hydroxybutyrate or urine ketones that are moderate or large. Of note, if you're on a medication that can cause you to have false positive urine ketones, then using the serum is obviously a better option and safer. As far as clinical manifestations go, we're pretty familiar: very dehydrated, tachypnic with Kussmaul breathing, nausea, vomiting, belly pain. They can be confused and drowsy, but they often maintain their normal to elevated blood pressure despite having a pretty substantial degree of dehydration. This is thought to be related to elevated catecholamines, some increased ADH release in response to the osmolality from dehydration, and then increased osmotic pressure from the degree of hyperglycemia. As far as who do we see with DKA, we see it in our type 1s and our type 2s. We see a lot frequently in new onsets. Anybody that has a lack of insulin, so pump failure, not taking insulin, a lot of sometimes psychosocial issues with obtaining insulin, and then sometimes with these kids that have gastroenteritis that just can't keep up their need for insulin, they can't sustain with the amount of vomiting that they're having. So a brief review: I know everybody is very familiar with this, but we really just see the combination of having this insulin deficiency with a stress and then the upregulation of the counter-regulatory hormones, so your glucagon, cortisol, catecholamines, and growth hormone. This creates like a perfect storm. So you're breaking down fats to generate energy, and the byproduct is ketones, and you're driving this acidosis. And then the rest of it is very ineffective, either unable to use the glucose or in an effort to manage what appears to be starvation, making glucose and breaking down glycogen, right? So we're increasing the blood sugar and creating worsening the acidosis, which is really the opposite of obviously what we would like to go for, but the system is just kind of snowballing. And so the higher the blood sugar gets, the worse the osmotic diuresis is, the more loss of water and electrolytes, the worse the dehydration, the higher the osmolality gets, the lactate from the poor perfusion feeds back into the acidosis. You guys know how it goes. And then the hyperglycemia has been pretty well associated with an increase in pro-inflammatory status and with insulin resistance. And so that really feeds back into the system and also creates a whole other problem with the raging cytokines and chemokines and the inflammatory status there. So we know that the potassium and phosphate are victims of these things, and so often their labs look normal, but they have pretty dramatic changes as soon as you start treatment, right? So the acidosis, the hypertonicity, the glycogenolysis, and the proteolysis cause, intracellular to extracellular shift of potassium, and then we're losing potassium with the vomiting and the diuresis, and then the depletion of volume leads to a hyperaldosteronism, and then you're peeing out your potassium, so you're just losing it in every direction, basically. And your phosphate follows a pretty similar pattern, and so we get this risk of arrhythmia as well as a risk of pretty severe hypophosphatemia, which can cause all kinds of different things, but particularly poor perfusion. When you decrease your ATP, you decrease your 2,3-DPG, and that shifts the hemoglobin's affinity for oxygen, and so it becomes more wanting oxygen and less likely to release it into your tissues, and so your perfusion decreases even more. So how do we manage DKA? The ISPAD guidelines basically say it needs to be in the ICU or in a facility that is well-versed in managing children that have a hyperglycemic emergency, where you can do all the things that need to be done. Your goals are to correct dehydration, acidosis, reverse ketosis to prevent further production of acidosis, gradually restore your hyperosmolality and glucose back to normal, monitor and prevent acute complications, and obviously if you see any underlying etiology or precipitating event, to treat that as well. So this is just a quick review. So you get all your labs, you look at your patient, right? Make sure that their neurologic status is intact. You don't need to be intubating and doing other kind of resuscitative measures. Determine the level of severity. So the ISPAD defines this based off of pH and bicarb. So essentially moderate is between 7.1 and 7.2 with a bicarb of 5 to 10. And if you are above that, you are mild. And if you are less than that, you are severe. Minimal dehydration and tolerating PO is pretty mild DKA. Probably we can make pretty few moves and get better. Moderate is really just not in shock is kind of how they define it. They say if you have perfusion, you're considered moderate. If you have poor perfusion, you're considered to be in shock and you're severe. So that's the biggest difference. So our patient meets criteria for moderate DKA. Her pH is 7.16, her bicarb is 9, and she is moderately dehydrated. So here we just kind of have the beginnings of management. We've defined how sick you are, and then if you are moderate, you get a bolus. There is some interesting controversy that we'll talk about a little bit about the IV fluids and the rate at which you can do them and which ones you can use in DKA. Essentially, you need to give a bolus to restore perfusion. If you feel like you need to repeat it, you certainly can. And then calculating fluid requirements. So looking at your maintenance need and your deficit, but not including urinary loss. We do not replace urinary loss in DKA. And then planning to replace over a total of 24 to 48 hours. Their recommendations say that the tonicity of your fluid should be between half normal and normal. And that you should be replacing potassium once your potassium level is 5.5 or less, and phos as soon as you start to see the level drop. If you are in very severe DKA, obviously you should do all of the resuscitation things and then bolus until you can get perfusion, and then move on with your maintenance fluids in rehydration. We start an insulin drip. Most people, we prefer to start at 0.1 units per kilo per hour. Should be started about an hour after you've started your boluses. And if you are really sensitive, you have a kid that's super sensitive or their pH is not quite as low, you can start them at half of that. Obvious tips: do not use IV insulin bolus. That can put them into shock and also can exacerbate hypokalemia and precipitate pretty severe arrhythmia. This is something that we sometimes see when kids come from outside hospitals, so we try to make sure people aren't bolusing our kids with IV insulin at the beginning. So kind of interesting, the fluid controversy is about the etiology of cerebral injury in DKA and whether or not that is based on how quickly the osmolality changes in the serum. And so previously the thought was that rapid administration of IV fluids would cause the rate of which you are decreasing the serum osmolality to exceed what the brain cells could keep up with and cause cerebral edema and be the reason that we were seeing all this cerebral injury. But there's a PECARN study. PECARN did a study that was published in the New England Journal a couple of years ago that basically said it doesn't matter whether you do it fast or slow, and it doesn't matter whether you use half normal or normal, you get the same results. And so there's been a bit of a shift in the rate at which we are giving fluid and replacing and how we are treating DKA a little bit. So the rest of management, obviously they need to be monitored closely, right? There's a lot of things going on. We're trying to replace electrolytes, make sure that we're not dropping too quickly. Their guidelines say you're on your drip, you're on your fluids, and then once your blood sugar is 300 or less, add dextrose. At our facility, we actually start with 2 bags. So we have 1 bag that contains dextrose, the other is non-dextrose. That way we can titrate to get the rate of decrease that we want all of the time and don't have to kind of switch around our fluids. Our goal for decrease of blood sugar is 50 to 75. Obviously, if they're improving, doing well, their acidosis is resolving, and they can look like they probably can tolerate PO, we can move them to transition to sub-Q insulin. Obviously, we start that before we stop the drip. If they look like they're going to keep puking, probably not a good time to transition them to sub-Q because you're going to get back to where you started. If they're not improving, if you're like, this bicarb looks no better than it did like 4 hours ago, probably something is not right. So looking at whether or not they're not getting enough hydration, if their perfusion is poor and you're having, recurrence of lactic acidosis, are they actually getting the insulin, are they septic, etc. And then watching for cerebral injury, which interestingly, they have changed the name from cerebral edema to be now cerebral injury in their paper. So looking for the warning signs, are they having these like really aggressive headaches that don't make sense for dehydration? Are they inappropriately having bradycardia? Are they super irritable? Are they just not acting right and seeming to be not where they should be? And then treating the cerebral injury appropriately. So the complications of DKA, the mortality is primarily related to cerebral injury. It's not a high rate. It's less than 1% in developing countries. It's closer to 10% or less than 1% in developed countries, closer to 10% in developing countries. We know that there is some subtle effects on the brain with every episode of DKA, even if there are no noted or gross complications during it, which is very interesting that they're starting to see some more significant and able to quantify some of this loss. There is frequently at AKI, we see that most of these kids come in with a creatinine that's pretty significant, but we see a lot of improvement with hydration. And then a lot of the complications have pretty significant overlap with HHS, which we'll touch base on later. The biggest one I want to talk about is cerebral injury, because this has had the biggest shift in the way that we view this and the way that we treat DKA. So the incidence is less than 1%, but the mortality rate is almost 25%. So pretty significant when it does happen. So we talked about earlier, we thought if we changed the osmolality of the serum too fast, we were going to cause cerebral edema. But that is no longer believed to be true. So currently, the thought is more along the lines of some animal models that we have been able to study and some things that they've seen in people who have had recurrent episodes of DKA. And so looking at concern for cerebral hypoperfusion related to their degree of hypocapnia and vasoconstriction, as well as a hyperinflammatory state being driven by the degree of hyperglycemia, playing pretty significant roles. There is some evidence of neuroinflammation and blood-brain barrier disruption, particularly looking at some of the metalloproteinases, and the degree of cerebral edema really seems to correlate with the rate of dehydration and hyperventilation, which really just reinforces the hyperinflammatory state and hypoperfusion. The people that are at the highest risk are young, new, long duration of symptoms, increased hypocapnia and acidosis, and an increased BUN. So they actually have given diagnostic criteria now that are much more specific than they previously were. So you either need one diagnostic, two major, or one major and two minor. So basically, do you have evidence of like pretty severe brain changes? Like, are you not responding? Are you posturing? Like pretty obvious, like you should be worried, right? And then there's just kind of like they're altered, their heart rate is changing, they're incontinent. And you're like, well, is it because we're giving them a ton of fluid and like they don't normally get this rate of fluid, or is there something wrong? And then the minor criteria: vomiting, headache, not arousable, diastolic blood pressure rising, and just being less than 5. And they say that the clinical diagnostic criteria is about 92% sensitive, and that you would expect to see these signs about 12 hours into treatment. So the treatment, we use hyperosmolar agents. Mannitol is the preferred. It should be you should see evidence that you have given the mannitol about 15 minutes afterwards. If you don't see evidence of improvement, then you can go ahead and use hypersal. Additionally, if you do see the effect of mannitol, you should expect it to last about 2 hours or so. Obviously, want to make sure that they're perfusing, their blood pressure is appropriate. If intubated, make sure that their gas looks appropriate for the level of acidosis and that we're not creating a hypercapnia. And then treat first and image second is a big point that they wanted to make. Don't image these kids immediately, treat them first and then look, because we frequently don't see anything exciting on imaging. So next case, patient B, 12-year-old male, no real medical history besides autism and tuberous sclerosis. He presents with weight loss, polys, vomiting, poor appetite, fatigue, and confusion. He's a little tacky at 114. His blood pressure is within range, and his respiratory rate's 22. He's awake but confused. He's very thin and emaciated. He's dry. He's tachycardic. He looks pretty, his cap refill is delayed, but his pulses are okay. So when we look at his labs, his sodium is 124, but corrects to 141. His glucose is nice and high. It's 1163. His bicarb is 18. His osms are 334. The VBG shows a pH of 7.28 and a bicarb of 23, small ketones, and large glucose. So definitely not looking at DKA this time. We don't have really ketosis, and we definitely don't have acidosis. And so this kid meets the criteria for HHS, right? So his glucose is greater than 600, his osms are greater than 320, he is not acidotic, and he really doesn't have significant ketones. I'll be honest, we don't see a lot of just straight HHS in our pediatric population. We see a lot of mixed, which we'll talk about in a little bit. So you all have a lot more experience in managing just straight up HHS than I do for sure. So despite severe volume depletion and electrolyte loss, their intravascular volume is well maintained by this degree of hyperglycemia and hypertonicity. And so sometimes their degree of dehydration is not interpreted properly. So the clinical manifestations are not super different than DKA, except that they often are more likely to have altered mental status without actually having cerebral injury. So who gets HHS? Pretty much most of our patients that get DKA also get HHS. There is I read that neonatal diabetes is more likely to get HHS than DKA. I have never seen that, but that is very interesting to note. Kids with cystic fibrosis, your type 1s, your type 2s, atypical antipsychotics, and corticosteroids. So, it looks very similar to what we looked at earlier. You're really just missing that top part. You're just missing the lipolysis, right? So you're not driving the ketosis, but everything else is pretty much the same. You have 3 reasons to be driving your hyperglycemia. It's driving your inflammatory. All of the things are happening. You have worse labs. Your electrolytes are more severe, and your osmolality is like crazy. It's driving up as your dehydration is intensifying. So the management is not it's different, but it's not crazy different, right? So we bolus these patients, but my understanding, and you guys can tell me if this is not true, but we pretty much bolus them until you feel like they have had appropriate reperfusion, and then start them on IV fluids. You use your total body deficit, or the fluid calculation that you use for requirements is your deficit plus, assuming like 12 to 15% dehydration, plus your maintenance, plus urinary losses are being replaced. They recommend half normal for replacement of your urinary losses. And they also recommend using IV fluids that are a little less tonicity than we use for DKA. So they recommend half to 3/4 normal. These patients also need to be on prophylaxis for venous thrombosis, whether you're using mechanical or biochemical, although I think most people use pharmacological, at least we do at our facility. And then you need to basically leave them on fluids until their blood sugar is not dropping at a rapid rate anymore, at which time you can initiate insulin at a much lower rate than we would for DKA. Obviously, the same things apply, so add your potassium, your phos, and your dextrose as needed to prevent you from having further worsening of your vascular status, as well as your hypophosphatemia and hypokalemia. Make sure I didn't miss anything. Okay. And then you're replacing your urine output at a 1-to-1. So the big highlights of DKA versus HHS. In DKA, we obviously see the acidosis and the ketosis with a less severe increase in the blood sugar, versus your HHS. You really don't have the acidosis or ketosis, but you have the really dramatic increase in blood sugar that's driving that osmolality up. So treatment, the differences are volumes of fluids, right? So we use a lot more fluid in HHS than we do in DKA. The timing of insulin is much later in HHS, and they advise to monitor the decline in serum sodium much closer in HHS. They really don't recommend using that in DKA anymore. And then electrolytes, obviously, you are watching your potassium and your phos and your mag, but you're watching them a lot closer in HHS because the derangements are more severe. As far as complications go, we talked about cerebral injury and really it being more common in DKA, which is interesting because most of the patients that we see, at least with HHS or a component of HHS, present with an altered mental status, but seem to have improvement with treatment and don't actually have a prolonged change in mental status or cerebral injury. As far as thrombosis goes, it's pretty heavily responsible for a lot of the complications we'll talk about, and it's believed to be related to the effect of the hypertonicity causing osmotic disruption of the endothelial cells, which then triggers release of the tissue thromboplastins and elevated vasopressin. And then the dehydration and the stasis also make a state of hyperviscosity and further contribute to the procoagulable status. So you have quite a few moving pieces that are contributing to that, and they cause quite a lot of the complications that we'll see. So patient C, 10-year-old female, known type 1, vomiting, headache, malaise, dizzy, pump died, unknown amount of time ago. Diagnosed with diabetes at 8 years of age. She's on a pump, and A1C was 12 at the last visit. So we see some tachycardia at 120, blood pressure is 108 over 48, and respiratory rate's 24. Looks pretty thick, pretty dry, Kussmauling, tachycardic, non-tender, but cap refill is pretty delayed. Our labs look not so fabulous. So our bicarb is 5, our glucose is 685, our osms are 338, our corrected sodium is 143, pH is 705, bicarb of 7, glucose is 1,000 or greater than 1,000, and ketones are large. So I know you're surprised by what this is, but this is our mixed DKA-HHS. And this is interesting, at least it's interesting to me, I should say, because this has not previously had biochemical criteria used to define this state before these guidelines came out. There was like 1 or 2 papers in 2010, 2011 that kind of identified this was in existence, and we needed to be careful in the way that we treated it, and that we needed to use some of the management techniques from HHS in these patients, but there were no specific cutoffs or really good guidelines on what to do when this patient comes in. And so that left a lot of kind of like, well, how much fluid do you give them? How much do they need? When is enough too much? Like, where are we and how should we be proceeding with these patients? And then like, what really is this combined DKA-HHS? How much of it is just because they're really dehydrated and their glucose is elevated? Where do you draw the line and say, okay, these are the patients that need a lot of fluid, and these are the patients that don't need to be quite as aggressively resuscitated. And so the ISPAD very nicely came out this year with guidelines that are a little bit more specific than before. And so they basically say you have to have a combination. So your blood sugar needs to be above 600. You need to be acidotic enough to qualify for DKA. Your osms have to be high enough to be HHS, and your ketones need to be high enough to be DKA. So they present with a combination of all the symptoms, as you would expect, and a lot of these kids are altered. We see this more and more. They say that this is like 14% of hyperglycemic emergencies in the literature that has been published. There have been a few more papers that have been coming out in the last like 3 or 4 years that have been touching on this mixed DKA-HHS, or they call it HDKA. And they all recommend a general same type of treatment, but anecdotally, we've been seeing this a lot. Like, I feel like, I don't know, 30–40% of our kids that come in are mixed DKA-HHS, and not as often are we seeing so much straightforward DKA. So the pathophys, pretty much as expected, right? So you have all of the things are happening. You're driving the acidosis like you do in DKA, but you're also getting this effect of hyperosmolality, likely because this has been going on for a longer period of time, and so you've reached a more significant state of dehydration and have kind of gotten to this further point. And so we see a lot more symptoms. We see a significantly worse dehydration, and the complications and the morbidity and mortality for this mixed DKA-HHS are much higher than what we see for DKA alone. And since we don't see a lot of HHS alone, this for us is the one that has the most significant issues long term. And so the guidelines are kind of like, you should be in the PICU. We should be monitoring all the things that we do when we monitor DKA and HHS. We need to make sure that you have enough fluid, and we know that it should be more than the kids that have DKA. We should be replacing urinary losses like we do in HHS, and we need to remember to account for all of the complications that we see in DKA and HHS in these patients, and sometimes expect that they may be worse than we would see in those individual presentations. So this looks pretty much the same as the HHS one, but it's a little bit different. So we bolus, right, until we feel like perfusion is attained or is improved enough. And then we calculate what our fluid requirements are the same way that we do for HHS. But then there's this big star, because when are you supposed to start insulin, right? So they say like once you've hit the point of appropriate perfusion, but like when is that? Is that after 2 boluses and an hour of fluids? Is that 3 boluses later? Is it 1 bolus and 2 hours of fluid? There's not really any very specific like parameters that you're looking for. It's mostly like, let's get their vascular status improved and get perfusion happening, and then we need to start moving the acidosis, but not too quickly, because as we start improving their acidosis and their hyperglycemia, then we have that risk of vascular collapse, because the hypertonicity is what's keeping us in a state of not having our vascular system collapse and keeping everything intravascular. So there's kind of this just like, I'd like to put a star there because it doesn't really have an answer quite yet. Nobody has given really specific guidelines, but it's really important. It's kind of the defining feature of what we're treating. It's like, when do we add the insulin? What, how do we do it without precipitating shock, essentially? And so that's the big question mark. And nobody has really been bold enough to come out and say, okay, here's what we're looking for. Here's what we're defining as an appropriate time. But I think as we recognize this more and more people publish about it and we're able to study it more definitively because we're seeing it so much more and we've recognized it as a separate entity, I'm hopeful that the next ISPAD guidelines will give us more specific and more practical help in how to proceed when we're kind of in this in-between. So complications, we talked about the rate and risk of complications in combined is much higher. So hypoglycemia, obviously, in all of these, and then the electrolyte abnormalities, so hypokalemia, hypophos, calcemia, low magnesium. Your chloride can go either way. Either you have too much and you become acidotic, or you have not enough and you became alkalotic. These are, the hypokalemia and phosphatemia are much more severe in the combined, but they obviously are also present in the DKA. The cerebral injury is usually seen more in DKA and less in the combined, but it's certainly a possibility. We talked about the thrombotic state that these patients are in, and so a lot of these things, like their, cerebral venous sinus thrombosis, basilar artery thrombosis, all these different intracranial processes, the pulmonary embolism, DVT, et cetera, all stem from that. And then you have this mucormycosis and aspiration pneumonia that are often seen, as well as pulmonary edema, ARDS, pneumos, all different air getting into the wrong places, cardiac effects, including hypovolemic shock, and arrhythmias from the electrolyte abnormalities that we had earlier. They have the chance of ischemic bowel necrosis, acute pancreatitis, rhabdo, renal failure, and this malignant hyperthermia-like syndrome that looks like rhabdo, but you also have a fever and you try to treat it with dantrolene, but nobody is totally sure on how exactly it is that you develop this syndrome. So it's kind of an interesting hand waving, but it's definitely a thing that's been reported. So the mortality in HHS and the combined DKHHS is more likely to be related to severe hydration, hypertonicity, and the electrolyte disturbances versus just the cerebral injury in DKA alone. So this is patient D. Patient D is a 13-year-old female with type 1. She presents with vomiting times 2 days, and her glucometer said HI high. So she was diagnosed at age 4. She's on MDI, and her most recent A1C was 12.5. Her heart rate, she's tachycardic to 130. Blood pressure is 122/64. She's breathing kind of quickly. Respiratory rate of 35. She's awake, but not really into communicating. Pretty somnolent. She looks pretty dry. She's tachypnic. She's tachycardic. She's non-tender, but her cap refill is not fabulous. She has all the things, so her bicarb is less than 5. Her glucose is 1292. Her osms are 396. Her corrected sodium is 154. pH is 706, bicarb of 6. She has glucose and ketones in her urine, and her A1C today is 13.1. So she is admitted. We do all the things that we talked about in the flow charts. She has an AKI on admission, but improves very nicely with rehydration. Her acidosis resolves. Osmolality improves around 36 hours. She's got a little hypophos, but it's being treated, and her potassium's a little low. And then she developed like very acute abdominal pain. Like, we were seeing her and we touched her abdomen and she screamed. And we were like, this seems dramatic. But she continued to have pretty intense abdominal pain, and so they got a CT, which had some news for us. So she actually had acute necrotizing pancreatitis and had a pretty significant necrotic collection surrounding the pancreas. So labs were obtained, lipase of 557, amylase of 353. She luckily did not require surgical intervention, and so she did stay in the PICU for an extended period of time and remained on a drip with fluids until she was really in a better place where we knew she'd reliably be able to eat, and we could get her enough insulin to prevent restarting ketosis. And once she was able to tolerate PO, she went back to her sub-Q regimen and did pretty well. She has had a few bouts of recurrence of the pancreatitis and a few admissions, but it overall seems to be improving with time. All right, patient E, 15-year-old male, no known diabetes. His history is really significant for obesity, and he's a very active athlete. He plays football and wrestles, etc. He presents looking pretty awful. He's altered. He's got in pretty significant respiratory distress. He's got polys, like 20 plus pounds of weight loss in the past 10 days. He was seen in an outside hospital. Their initial concern was anaphylaxis prior to obtaining labs, and so he got epi and 2 doses of solumedrol, which really worsened his status in glucose. So his vitals were, he was tachycardic, he was hypotensive, his respiratory rate was fast, he was 40. He looks very ill, he's dry, he smells like ketones, he's tachypnic, he's tachycardic, he's non-tender, he's lethargic, he really only follows very simple commands. His labs are not fabulous. His osms are 412. His corrected sodium is greater than 146 because his glucose is greater than 1500 after those doses of solumedrol and epi. His bicarb is 5. His pH is 7.1. His CO2 is less than 18, and his bicarb is 3.7. So he's pretty sick. His glucose is greater than 1,000. He has large ketones, and his A1C is 12.7. He received 3 liters of normal saline, 14-unit insulin bolus of IV insulin before he was transferred to our facility. So a little dangerous, but he got some fluids, so he did okay. So he is in the ICU receiving very aggressive IV fluid replacement with urine replacement and insulin drip. He has a pretty significant AKI with a creatinine of 3 on arrival. He's hypokalemic. He's hypophosphatemic. Less than 24 hours in, he becomes very altered and is trying to pull out his lines, trying to leave the hospital, doesn't make any sense. So he gets a dose of mannitol. He gets better and then redevelops very persistent agitation, develops acute respiratory failure, has a fever. He goes on high flow, needs pretty significant respiratory support. He develops leg pain, and we were like, that's weird. Of all these other things, let's grab a CK. So his CK was elevated. It was elevated for several days and actually peaked at 187,000. His myoglobin was 555. So we got pediatric nephrology involved. He was on more fluids, and then we added bicarb to alkalinize the urine and protect the kidneys, but that further complicates the picture when you have some acidosis and you're already replacing a lot of fluids and you're on high flow for respiratory failure. And we're like, how much edema do you have? How do we give you more fluids to protect your kidneys and give you bicarb in your fluids without making more of a mess than what we have going on? And then there was some question of, is it rhabdo or is it this hypothermia malignant syndrome? What are we looking at? Do you have an infection and rhabdo, which is what we settled on in the end? He received Rosafen, and he did recover. He did eventually get to transition to a subcutaneous insulin regimen. He was very deconditioned. He was in the hospital for several weeks, and he ended up going to Frazier, and then he went home, and he's playing football and wrestling and doing all of those things. But I think this brings up a lot of interesting points. One, he had 1,000 complications in a very short period of time. He came in and had the whole list of things, minus a PE. And he required pretty extensive rehydration, and I think we found out along the way that maybe we didn't know as much about treating rhabdo, some of the complications of this combined DKA-HHS while still treating the DKA-HHS than we had realized, because I don't think we had seen a lot of this before, so we learned a lot of things. It also was an interesting thing of trying to decide how to treat him. So does he have rhabdo? Does he need all of these fluids? Or does he have this malignant hyperthermia-like syndrome? Because he has this rising CK and he does have a fever. Do you treat him with dantrolene? Do you treat him just with fluids? How do you decide what you're going to do? And so because he seemed to have an infectious source and his fevers were not persistent and he did have the pain and other things associated with rhabdo, we went ahead and treated him as rhabdo and separately treated his infection with Rosafen, and he did improve after extensive treatment. So how do we prevent this from happening? This is a huge challenge for our team. And I'm sure it's a challenge for all teams. So we see 3 different groups of people generally, right? So we see new onsets, people who don't previously have a diagnosis. So they come, they get a full education, psych sees them to kind of help with coping with a new diagnosis, chronic, and a lot of times for the parents, especially if we have toddlers or small kids, that's a whole another ballgame, right? And then social work sees if there are any resources and things we can do to help make sure that they can get all the things they need. We have kids who have isolated events, right, like a pump site failure or an illness that they just couldn't keep up with, that their ketones exceeded their ability to get insulin. We've really just kind of addressed gaps in knowledge, make sure they have everything they need, review sick day management. move on. Recurrent events. So psych and social work are involved. We have a big education team, our inpatient team and our outpatient team. So our inpatient teams for all of these groups see our patient during their crisis state. And then we have outpatient teams of all of these groups who closely follow our patients and stay in pretty good contact with our patients, families, and the schools, which is helpful that we have school nurses that are required to help us. And so we can keep contact with them. We do safety plans, and then we have some special high-risk clinics. One's called DART, and we try to follow them closely. So some of these kids we'll try to follow on a monthly basis instead of every 3 to 4 months, and try to make sure that we're keeping up with them a little bit closer until we get them in a better spot. And then obviously, like if we're concerned about neglect or they're in danger and some other things, we can get CPS and other teams involved to try to help us get safer and better care for these kids. So future directions, I think some of the biggest things are going to be, there was a study in Italy where they educated people on recognizing diabetes, and their rate of hyperglycemic crisis at onset decreased significantly because people saw like, hey, you have the symptoms, you should see a doctor, and it was caught when their A1Cs were like 7 and 8 instead of like 12 and 13 before their symptoms really drove them into a crisis state. I think, educating patients, current patients, and doing as best we can with our social work teams, our LCSWs, and our behavioral teams to try to help our patients to have the coping skills to work with having diabetes and make it part of their life and try to make it a more functional part of their life and less of the recurrence. The improved technology and closed loop systems have been phenomenal. I'm sure you guys have seen the same, but that's been life-changing for a lot of our kids. Like it does the things, even if I don't bolus at lunch, my A1C still drops by a ton, which is huge and keeps me in a much safer range. I think developing, as we do more research now that we have done a better job of recognizing this as a state, I think we will do a better job of developing more specific guidelines for treatment and prevention of complications. And then obviously like continuing to try to figure out, what is causing us to be in these states and how do we, continue to prevent or delay the onset of these things. So I read a bunch of papers that you can see here, and this is today's event code. Thank you for listening and participating through this experience. Anyone have any questions, comments, concerns? Sure. Thank you.
Just comparing it with adult population, especially during COVID, we had so much more HHS and
Really?
and we do see mixed also. Our protocols, we have initiated insulin fluids in both of them together, which is very different.
Yeah.
We use the Pediatric guidelines, pairs from that.
Yeah.
So, and then we just the sugars, we stop transition to dextrose at a higher blood sugar for HHS as opposed to adding more dextrose. So, one question I had is, given all these different things, do you put a PIC line or something in this pad?
We usually
so much more scary.
No, that's a very good question. So we prefer to do 2 peripheral IVs or as many as we can get, hopefully 2, because the rate and risk of thrombosis with a central line or a PIC is really high. And so we do everything we can to prevent that. We did the other day have to put in a central line and just make sure that they're getting enough anticoagulant, but we prefer not to because the rate of thrombosis is pretty high if we do. Yeah, so we do our best to do 2 IVs and every once in a while an IO to get them hydrated enough to get an IV. Yeah.
Then the costs, at what level do you start with it?
So we actually have FOS in our initial fluids. So we have a little bit. So we have K-FOS, sodium acetate, and half normal is what our fluid. It's a 40 K-FOS, sodium acetate, and half normal is what our fluids are made up of. And so both bags of fluids have that, and then one has like 12.5 of dextrose. So we start there, and then we add more as we need and try to make sure they get some Fosnac oral supplements at the end too.
And I like that bolus because you have that in that potassium is less than 3.3.
Right. No. Yeah.
And over 5.5 stuff. But adding the fluid, potassium to the fluid is the FOS.
Yeah.
Something we don't have in the protocol.
Really?
It's pretty severe.
Less than 1.
Yeah.
Huh.
Because in adults, at least, the cough doesn't seem to cause a problem. Because it corrects as.
Yeah, interesting. We seem to see a persistent low FOS.
So really different.
And in a lot of the new onsets, they're so cachectic, we're worried about a little bit of refeeding syndrome too. And so we try to be careful and make sure that they're getting enough FOS supplementation. So a lot of times we'll do FOSNAC too, just to continue it after they're off the fluids to give that oral supplement of all three.
Is there any literature to say that kids who present with combined DKHHS, present recurrently in that?
There is not any literature that has looked at that yet. There is very little literature out about DKHHS combined almost at all, to be honest. A lot of it was initially like, we have DKA and then we have this version of like this hyperosmolar version and you should give some more fluids, but there wasn't a lot more about the pathophys of it and kind of, what is the pattern that we're seeing. I think that there are a lot of people looking to do more studies in pediatric patients now. We really don't, all of our guidelines for mixed and for HHS only are based on the adult guidelines because there aren't any studies in kids.
One of the things is because, so we assume that, you develop insulin, if you don't take insulin, all of those things. But the thing is that it varies a lot in the sense that there are people who can go for a week without insulin and they won't, and there are people who miss 2 doses of insulin. And the degree of acidosis that one develops also differs. And there's some pattern to it. That means people who develop severe DKA, acidosis, tend to do that every time they have a cough. So there have been studies that have looked at the ketogenic pathway, looking at the different enzymes, and they have identified certain patterns, where you can say that certain isoforms of these enzymes are there's mutations, so that the presentations will vary depending on what business. So and this is in the adults. So particularly because people have been studying this what we call fetus combat. They're not
they're antibody negative, but they're producing ketones.
So when they studied them, they also studied doses in general, and they were able to find them. So do you have any pediatric population?
I don't know of any studies per se. I can say anecdotally that the first patient we talked about, patient A, has had several episodes of recurrent episodes, and she has had both DKA and mixed DKA-HHS. So that one was DKA, but I think the last one was mixed, and then there's been quite a few in the last 6 to 8 months, and there have been a combination of them. She's had both. As has the patient that had pancreatitis, has had both DKA and mixed DKA-HHS. So it doesn't seem to be reliable. It does, and because, I have not found a reliable pattern. I found some of these kids are having both at different times for reasons I definitely cannot explain, at least yet. So hopefully we'll get some more literature in the next several years about this kind of thing.
What is the relation for one of the minor criteria for the cerebral edema was age less than 5.
Less than 5.
So why is age, because we rarely see that.
So there has not been a lot of good literature to describe this, and I don't know if it's because they don't communicate as well, and so you baseline start out with a little bit more as like a step up, I guess I would say, in the criteria, so that you don't have to meet as many things because maybe their mentation isn't as obvious when it changes. They do say that the risk is higher in those kids, and it's not clear if it's because it's more difficult to recognize and that they don't have all of these things that they do. They don't have all of the same interactive capacity that we would expect of a 13-year-old, so it's much harder to determine that their capacities are lower than they would have or we would expect. So they don't really explain if there's a pathophysiology that's very specific and it delineates them to have a higher risk. I've not found that yet. It may exist, but I haven't read about it yet, so I don't know about that.
One of the things we see in adults is glycemic decay with the SGLT2, which we don't have SGLT2.
So
do you see something?
We do sometimes, and so their recommendation was really just to start dextrose fluids immediately, like as soon as you bolus them. We did. We actually had a kid the other day that had gastro pretty bad, and so we just couldn't keep up, and their ketosis got pretty rough, and their bicarb was pretty low, and so they went ahead and we treated them for euglycemic DKA. So not super common, but we do definitely see it.
Do you have any questions? Just share.
Okay. Could knowing genetic predisposition for type 1 help to an early diagnosis and treatment? Yes. So we would ideally, that's kind of what the TrialNet studies are following and other things. If we know that these kids have a high risk of developing diabetes, then we can follow them more closely and ideally prevent them from having hyperglycemic crisis and be able to treat them, and follow them and know when they're diagnosed and be able to kind of titrate their treatment appropriately at that time. So yes, good question. That's the goal. Yes, sir.
Now, it seems to me that anybody that has a very high glucose and it's DKA, then they're going to have a hyperosmolar syndrome going on. Right? So
if it's high enough to drag your osmosis up high.
To what extent is it affecting the overall illness or the overall syndrome?
Meaning the degree of hyperglycemia affecting your treatment or your pathosis?
If you're type 1, let's say, and you're in DKA, and I don't think usually the glucose doesn't get up.
So we are seeing that quite frequently now.
If it starts getting up very high like that,
it's more.
a lot of times it's 400 or something. Because you're producing a lot of ketones because they're not able to get glucose.
But they're beginning to see a lot of mixed picture.
We're starting to see a lot more mixed picture. And we did a couple of these cases had blood sugars in the thousands, and they are known type 1s that are triple antibody positive that have had, undetectable C-peptide for several years and were diagnosed early as toddlers.
Is it because they are higher BMI?
No. None of those. One of those kids has a higher BMI, but the rest of them do not. Yeah, there's no really obvious pattern, unfortunately. And I think that this is going to be a time when we start to see more literature because people have finally come out and said, okay, this is a thing. Yes, we recognize it. And we also recognize we don't really have any data because we haven't really previously delineated that this is separate. So it seems to be that people are coming out with more about it now, but there's still.
We see a mixed picture.
Yeah, which is interesting.
So is it, you showed the early, the ethnic changes.
Yeah.
Where the type 1 is more, they're all catching up to the non-Hispanic white. So
yeah.
Is this mixed picture something related to that?
I don't know. So the patients that we had in the examples that we have are a mix of non-Hispanic white and non-Hispanic black patients were those patients. And some of them, they've had all of the above. And the HHS patient I made up because I don't have any just simple HHS patients. So that one is big.
In this study, was there a uniform definition of type 1?
Yes. But they don't detail it.
Because if you, in 2003, the antibody panels that we had compared to 2018, missed
a lot of people.
So did they go back and they excluded them, or did they only take patients?
They
have samples where they could verify that?
They did not specify any of that. They basically said they had a diagnosis and it was confirmed within the first 6 months. It's from the SEARCH study, but they don't delineate exactly how they made those diagnoses. So I can.
I think that would be important.
Yeah.
Because it, I think it was probably 2004 or 5 that we routinely did antibodies in all type 2 diabetes.
Interesting. Yeah.
Not for our clinical purposes.
Just for research.
Do a study on insulin for anything, whether it's Lantus or definitely all these new insulins that were introduced.
Yeah.
And we had to claim that this is type 2 diabetes. And you had to do an animal. And we used to find a good number over.
Yeah. Interesting.
And
in this slide, could I ask whether American Indians are Native Americans or South Asians living in America?
My interpretation of this is that they are Native Americans. This is the language that they use, but they are based on several reservations that are in the general area of Colorado and outside. So that is my interpretation. Yes, sir.
Thank you.
Sure, please.
So in the adults, we do them on I know you guys do that a lot lately.
We do.
So if you go back and look at your patients, they have started that, done some of it or tried it at home, or they just sort of get in here, especially now with the, continuous. I'm assuming majority of
a lot of them do have. Yeah, so it seems to be very closely follow kind of their adherence in general. So if they are generally adherent, they typically try to follow some sick day management. Yes, and the ones that have had it for a long time, generally, well, I shouldn't say that. So people who are at least adherent-ish tend to yes, or they call, and ask us what to do. The ones who are less concerned with managing their diabetes tend to be the frequent flyers who we have safety plans for and we have extensively educated on what to do, but that doesn't seem to be the differentiating. No, yeah, it's a big struggle. We are trying. And, I think that we've had we have a couple of really fabulous LCSWs who have really helped us in navigating some of those family dynamics and coping and helping, especially our teenagers, to cope with this diagnosis and reframing and really helping them long-term in managing their disease. And so that can be really helpful if we can get the buy-in from the patient and the family. That seems to be a dramatic change. But no, we really don't see a lot of meth in these patients. No, we see some weed, but we don't see a lot of meth. Yeah. Yeah, some of those toddlers for sure.
The patient was just using the section where they walked in and they were diabetic.
Yeah.
Trigger.
Yeah. Thank you. Thanks everyone very much. I appreciate your time.